Good morning. I'm Dr. Rajit. Let's start about ANS. So in the ANS, we'll see about two systems: parasympathetic system and the sympathetic nervous system. This SNS and PSNS, okay, they are the two systems, and sympathetic nervous system is basically based on emergency. That is the fright and flight. They are the emergency system, right? And parasympathetic system is the rest and digestive system, is known as the honeymoon system, right? Now in the sympathetic system, it increases the heart rate, right? Increases the heart rate, dilate the pupil, dilate the bronchus, decrease the DIT secretions, decrease the ACL secretion, relax the micturition, and there occurs the lipolysis. But what happened in parasympathetic nervous system? Heart rate is basically decreased. There is constriction of the pupil and bronchus, increase in the ACL or the acid in the stomach, increase in the peristalsis, micturition is increased, and lipogenesis. So in the rest phase, there will be lipogenesis, become fat, and in the anxious state, people become lean and thin, right? So now the anatomy basically is, if you see, they are the catecholamines. The catecholamines are the substances, amines, which are having the catechol ring. The maximum present in the body is the noradrenaline. In the kidney and GIT, it is present the dopamine. In the adrenal medulla, it is the adrenaline. So adrenal medulla is the only place where adrenaline is present, due to present of the we'll see in the later part, an enzyme is present in the adrenal medulla, which is not present anywhere in the body. Okay. Now there are two things, like let's say sympathetic nervous system, and it is known as the adrenergic system. This is the thoracolumbar outflow, or parasympathetic nervous system is known as the craniosacral outflow, is the cholinergic nervous system. Okay. Now 3, 7, 9, 10 nerves releases the acetylcholine, and this is the sacral pathway. This is the craniosacral outflow. The sacral pathway also has this craniosacral also has this parasympathetic innervations, right? Now this sympathetic cholinergic neurons are present only in one place, that is the basically the sweating. So what happens, like both places, we know that parasympathetic has presynaptic neurons have acetylcholine, and postsynaptic also has acetylcholine. But in the sympathetic, pre has acetylcholine and post has basically three things. Either it may be noradrenaline, dopamine, adrenaline, or even acetylcholine. So in the postsympathetic terminals, the neurotransmitter release is norepinephrine everywhere, in all places. In the kidney and GIT, there is dopamine, and adrenal medulla, there is adrenaline, as well as in the sweat glands, it is the sympathetic cholinergic neurons, and it is there in lacrimation gland also, and salivation also somehow. Okay, so basically there is sweating during the any adrenergic emergency situation, right? Now this parasympathetic nervous system or cholinergic system, if you will see the transmission, so what is basically we have to understand is acetyl coenzyme A, okay, will react with choline, and here this calcium will act as a inducer, and acetylcholine is getting attached with the membrane. So acetylcholine coenzyme A, with choline will form the acetylcholine, and this acetylcholine will be present in the in the synaptic vesicle, and this calcium will induce the attachment of this synaptic vesicle with the membrane, right? And there will be release of acetylcholine, and there it will act on the receptors, that is the N and M receptors, okay, nicotinic and muscarinic receptors. Okay. Now acetylcholine is then break down into the choline and acetate again by the help of an enzyme which is known as the acetylcholine esterase enzyme. So there is an esterase over here. Please note over here, it's Pseudocholinesterase is also present, okay, but mainly in the neurons acetylcholinesterase is present. So pseudocholinesterase is present in the periphery. Okay, so we will learn about succinylcholine apnea and many things in which there is some genetic difference in the patients, and there occurs the change. Right now, this choline acetate choline will be reuptake by the neuron in the, and this step is the rate limiting step. This is the rate limiting step, and this is inhibited by a drug called the hemicolinium. Okay, now the choline with acetylcholine coenzyme A will bind and act at this and to form this acetylcholine, but this process is inhibited by the vesamicol. Right now, the attachment is inhibited by the botulinum toxin. It blocks the calcium channel. Now acetylcholinesterase, you can see over here, this enzyme which is breaking the acetylcholine, due to which there will be decrease in the concentration of, if anything inhibits the enzyme, so the concentration of ACH will be increased. So these anticholinesterases are the carbamates or organophosphate. For example, this in the organophosphorus poisoning or carbamate poisoning, what is happening in this organophosphorus will act on so the organophosphorus poisoning, as we are seeing, that what will do, it will actually act on the acetylcholinesterase enzyme. Now the drug which is given is atropine. And oximes are used like pralidoxime. Now atropine and oximes will act on the these are competitive antagonists. These are competitive antagonists of the acetylcholine, because what will happen that this acetylcholine will be increased in large numbers. So when the acetylcholine will be increased in large number, there is overstimulation of the nicotinic and muscarinic receptors, and overactivation leads to some problems, like whatever the problems, like increase in all the lacrimation, sweating, increase of all kind of parasympathetic discharge. So what we'll do, we'll give an agent like atropine, and what will the action of atropine? Atropine will be competitive antagonism shows with the acetylcholine, and it will block the receptors. With no intrinsic activity. So even if the acetylcholine is higher, it will not able to act on the receptor. So over activity of the sympathetic parasympathetic discharge will be suppressed. Okay. Now botulinum toxin, as we know that botulinum toxin is because of this bacteria Clostridium botulini. The subtype is A, B till the H. A and B effect for the human beings is most lethal toxins known to humans. Used as the local injections as BTX-A in the treatment of muscle spasticity, echalasia cardia, blepharospasm, dystonia cervicalis, torticollis or wry neck, squint. Okay, in the cosmetics it is used in the wrinkle. There wrinkle is present in, like in the crow's feet in females, like their nose like this. These are wrinkles. These are like crow feet. Okay, so it will act on the Botox injection. Botox is given there, right? Hyperhidrosis. There is increase in the sweating. So there we can use Botox injection. Okay, these are the uses of botulinum toxin. Receptor of acetylcholine is nicotinic and muscarinic, as we have seen. Nicotinic is inotropic and muscarinic is the GPCR, as we have seen in the general pharmaco video. The muscarinic are the GPCR, G protein coupled receptors, and inotropic is the sodium, inotropic sodium channel based, and it is the nicotinic receptor is the inotropic receptor. So it is the NN and NM. M for muscle and for neuron or ganglia. So it is NN is present in the ganglia or neuron. Present in the postganglionic neurons of both sympathetic and parasympathetic activity, for example in the adrenal medulla Okay, now agonist of NN and NM will see that both have nicotine as an agonist, but in the antagonist, in the NN we have ganglionic blockers. There are ganglionic blockers. This is hexamethonium, D-tibocurare, mecamylamine, and trimetharphan. Trimetharphan is an IV drug used in the arterial surgery in the case of aortic dissection. Now, NM receptor we have NDMR. NDMR, that means the non-depolarizing muscle relaxant, and the examples are D-tibocurare, cis-atracurium. Now, which NDMR is also a ganglionic blocker? The answer is D-tibocurare, because it will act on the both on NN and NM receptors. They will block the both. In the cardiac surgery, vicodinium is the drug of choice as it is stable NDMR. Right? Now the effects is decrease in the sympathetic nervous system and decrease in the parasympathetic nervous system. In the sympathetic nervous system, if it decrease, it will lead to postural hypotension because of the vasodilation. Okay? It does not have a atropine like effect. Now in decrease in the PSNS will cause the atropine like side effects. Okay? Now what are the drugs used in arterial surgery? So example is EAT. Trimetharphan we have seen, adenosine and esmolol. One beta blocker esmolol, adenosine and trimetharphan are used in the arterial surgery. Okay? To control vasodilation of the hypotension. Okay? Now muscarinic receptors, there are 5 receptors, M1 to M5. Okay? Location is present, CNS is present in CNS, all type of receptors are present. So increase in acetylcholine will increase in the memory. Okay? So it will increase in the memory, so it is given in the Alzheimer dementia. Now in Parkinson what happens? There is decrease in the dopamine, lead to unbalance and increase in the acetylcholine. So it leads to increased acetylcholine effect as well as decreased dopamine effects. Now peripherally, in the stomach there is M1 receptor, in the heart there is M2 receptor. Okay, so in the heart sinoatrial node and AV node are inhibited, and in the stomach HCl is decreased. Now acetylcholine normally will be causing in the blood vessel vasodilation, okay, but in the injured blood vessel it will cause vasoconstriction. Okay, now rest of the body, in the glands it is increase in the sweating, lacrimation and salivation. In the endothelial cells there is increase in the nitric oxide production and leads to vasodilation. In the smooth muscle they'll lead to contract, there is vasoconstriction, bronchoconstriction. Bladder lead to micturition and relaxation, and intestinal leads to diarrhea or peristalsis. In the iris it is called meiosis of the due to circular muscles, and very important thing to understand that in the circular muscle there is sphincter pupillae, right, and this sphincter pupillae will cause meiosis due to presence of the receptor M3. In the radial muscle, dilator pupillae, which is lead to contrast and mydriasis due to sympathetic nervous system alpha 1A receptor. So alpha 1A and M3 are the receptors in the contraction and relaxation of the pupil. Now M1 odd numbers M1, M3, M5 are GQ based, finally leads to the IP3, DAG and calcium, whereas the even numbers M2 and M4 for the GI, that is decrease in the cyclic AMP. Also there is a potassium will move out, open in the potassium channel, and hyperpolarization leads to inhibition of the SA node. So M2 is present in the heart, and this is how it works. M1, M2 and M3 will see the agonist of M1 is important, that is the pyrenzipine and telenzipine. M2 agonist is methacholine, M3 agonist is bithanicol pilocarpine, and M3 antagonist is dariphenacine and solifenacine. It is a very important urology question, that dariphenacine and solifenacine are M3 antagonist that is present in the bladder. Now cholinomimetics or PSNS mimetics directly acting at the receptor agonist कौन सा होगा? These are esters and alkaloids. The esters the esters will have this CHOL col, and the alkaloids will have an INE in the end, right? Now what will the examples? The esters are the acetylcholine, these are the shortest. Bethanicol is the M3 agonist, carbachol and methacholine, that is M2 agonist. Okay, so these are the esters, and in the alkaloids there are pilocarpine, ericoline in the erica nuts, nicotine, muscarine and lobeline in the lobeline. Now acetylcholine is shortest because of the presence of pseudocholinesterase present in the plasma. So this is the butyryl cholinesterase also, right? Its name is the butyryl cholinesterase. The use of bethanicol is in the urinary retention. It is used. So we are discussing the use of muscarinic antagonist. Now bethanicol, if we are seeing that bethanicol, these are cholinomimetics. Right? So agonist. So this urinary retention is causing the detrusor muscle to contract. The non-obstructive urinary retention is there. Postpartum and post-operative, we give, there is atonic bladder. So to bladder to relax, we give bethanicol. Okay. Second is the paralytic ileus, that is the megacolon. There the bethanicol is used. The next is the methacholine. Methacholine is inhalational. Methacholine challenge test was earlier used. Is a provocative test for asthma. It is banned because of this severity in the response of the patient. So now we are doing the spirometry. Okay, so methacholine was earlier used as to provocative test for the asthma. Okay, now we will see that methacholine will act mostly on the M3 receptor, then M2, then M1. Okay, now and M3 receptor in the bronchus is hypersensitive. That's why it is used as a provocative test. It was used, right? Now pilocarpine, it has an occlusert, so ocular insert. Now topical eye drops we are using. A drug of choice is the mitotic agent in glaucoma to break the iris adhesions, that is the synechia. The oral, if you use a pilocarpine, increase salivation, the treatment of xerostomia in the Sjogren syndrome and cystic fibrosis. Sweat, lacrimation testing. So there is a role of buspirone and ericoline. So this buspirone is an anti-anxiety, and ericoline was betel nuts या पान में यूज़ करते हैं, erica nuts, right? Muscarine, poisonous mushroom. Inocybe amentia treatment is the atropine. It blocks the muscarinic receptor. Nicotine is used as a smoking cessation agent. So what are the drugs for smoking cessation? The first line drugs are the nicotine, either transdermal, gums or spray. Varenicline is the partial agonist at nicotinic receptor. It was an MCQ at NIMHANS. Buspirone is an antidepressant, norepinephrine dopamine reuptake inhibitors. Nortriptyline, clonidine. Clonidine is to decrease the craving of the. These are the nortriptyline and clonidine are the second line agent for smoking cessation. Okay. Now, indirectly acting agents are the now anticholinesterases. So this will decrease the acetylcholinesterase, pseudocholinesterase. The reversible inhibitors are the carbamates, the safe in patient, and irreversible blockers are the organophosphate, which are acting as a poison. Reversible carbamate are tertiary amine, that is NH3. Quaternary amine are the drugs which are hydrophilic, and tertiary amine are lipophilic. Oral bioavailability in the lipophilic agent is good. It will cause the blood-brain barrier, it crosses the cornea, and used in the treatment of Alzheimer's. So tertiary amine is used in the treatment of Alzheimer's, whereas quaternary amine has no such activity. Okay. Tertiary amine example is the physostigmine. It is used drug of choice for atropine poisoning. Topical eye drops is miotic in the glaucoma. In the glaucoma, miotic action is there of the physostigmine. Now drugs for Alzheimer's dementia is the tacrine. Now it is a banned hepatotoxic drug. Other drugs for Alzheimer's are the donepezil, galantamine, rifastigmine, as used in the transdermal patch. Okay. Now anticholinesterases, if not responding, we give the NMDA blocker, that is memantine, in the Alzheimer's. Okay. So these are the treatment of choice for Alzheimer's. Now nootropic drugs are the drugs which increase the memory, like ginger, ginkgo biloba, Paracetam. Okay, these are nootropic drugs. Quaternary amine, there is a neostigmine. This is used in the emergency because of IV formulation. It is NM agonist also. Okay, the other drugs like edrophonium or tensilon test will do. Pidostigmine and ammonium, these are quaternary amines. Neostigmine is a drug of choice for cobra bite poisoning. What happens in the cobra venom will actually have inhibition of the NM receptor. The patient died due to muscle paralysis. Okay, so we give antivenom, that is the drug of choice, but neostigmine if the respiratory depression is present, to save the patient, right? Neostigmine, there will be reversal, and neostigmine is used in the urinary retention and post-op ileus. Neostigmine is used in myasthenia gravis. A side effect of neostigmine is bradycardia and heart blockage. So used with atropine, there is the M receptor blocker. Okay, so it is used in the atropine. Now myasthenia gravis, it is an autoimmune disease. It is an antibody is produced. Now NM receptor is blocked, and that is called the weakness. The treatment is symptomatic treatment with the use of pidostigmine and atropine. Pidostigmine is atropine. In the emergency, we use injection neostigmine and atropine. The definitive treatment is immunosuppressants like methylprednisolone, okay, which is used as a side effect is Cushing syndrome, and azathioprine as a maintenance. The induction will be done by the methylprednisolone, and azathioprine is used in the definitive treatment of myasthenia gravis. Cyclosporine, cyclophosphamide, rituximab, and if we use in the treatment of myasthenia gravis, if there is no such treatment, thymectomy is the ultimate option. Now in the edrophonium test, edrophonium is the shortest acting. Diagnosis of the myasthenia gravis is there. Okay, there is sudden improvement and ameliorative test. This is the tensilon test. Okay, diagnosis of myasthenia gravis, there is sudden improvement. We use the edrophonium, and this is known as the tensilon test. The contraindication is D-tuberculin. It worsens the symptoms because it is the proactive test. Thymectomy, yes, we use in the thymoma, patient with thymoma, but we in the ocular myasthenia gravis we don't do the thymectomy. Myasthenia crisis, respiratory paralysis is there. Treatment, plasmapheresis, myasthenia gravis, and IVIG is the drug of choice. So IVIG is the drug of choice for Guillain-Barré syndrome, polymyositis, Kawasaki disease, and multiple sclerosis. The multiple sclerosis, other steroids, plasmapheresis, and monoclonal antibodies are used. Now, irreversible anticholinesterases, we have carbamate and organophosphate. In the carbamate, we have carbide, adicard, propoxur. In the organophosphate, we have malathion, parathion, sulthion, diazinon, TLK20, diflos, tabunsarin, soman, and VX agent. Now, in the bagon, we have chlorpyrrose and propoxur. In the andrine, we have organochlorine. Okay, it is not an organophosphate, it is an organochlorine. Now, organophosphate and carbamate poisoning, which we have discussed before, they have this dumbbells. Dumbbells means diarrhea, urination, meiosis, pinpoint pupil, bradycardia, bronchospasm, emesis, lacrimation, and salivation. Everything is increased. But death is due to respiratory paralysis, as there in the cobra poisoning. Yeah, right? The mechanism of action, decrease in the cholinesterases, so increase in the acetylcholine. So they have two sites, anionic site and esteric site, and there it binds. This is the enzyme, this is the bind, right? Now, organophosphate blocks the esteric site. It blocks the esteric site. Carbamate blocks anionic and both anionic as well as the esteric site. This is the difference. Atropine is the drug of choice for organophosphorus and carbamate poisoning. IV 2 mg per kg we give till the atropinization occurs. The pure sign of atropinization is the definite sign, decrease in the bronchial secretion we hear by the stethoscope, and decrease in the bowel sound, constipation is there, tachycardia, mydriasis is there. But the ultimate sign of atropinization is the patient starts abusing the doctor, or they have the abusive language used because of the atropine getting into the brains. Okay, and causing the patient to use the abusive words. Now the enzymes are the second line of choice treatment. They are the cholinesterases reactivator. It is only effective in organophosphorus poisoning in the early phase, but it is contraindicated in the carbamate poisoning. Enzymes bind to the anionic site, or enzymes bind to the anionic site. Okay, so it removal of the organophosphorus from the esterate site. It binds to the anionic site and leads to removal of the organophosphate from the esterate site. Now what will happen if phosphate will be bind for a long period, so it will causing the aging of the enzyme, and there is no role for enzymes. Okay, so it is not effective in aging of enzymes. In the IV, pralidoxim, obidoxim, diacetyl monoxime are used. Okay, the early cases of the OP poisoning. These are the drugs obidoxim and diacetyl monoximes. These can cross blood-brain barrier, but they do not cross the blood-brain barrier. Now we'll discuss the anticholinergic in the next video.